Welcome to the channel Nursing in Handy. This channel is preferably for the nursing fraternities to have a continuous learning in their profession. Today we'll be seeing about the topic Erythroblastosis fetalis. This Erythroblastosis fetalis is otherwise known as RH incompatibility or isoimmunization. So whatever the name is, the content is same. So if we are talking about RH incompatibility, also it is the same, and Erythroblastosis fetalis also the same. So before proceeding into the topic, we must know the basic concept of RH incompatibility. For example, if a mother is having a negative blood group, and she is her husband is having a positive blood group, so there is a chance of the baby they are going to get conceived may have 50% of negative blood group and 50% of positive blood group due to the father's blood group. So what happens is, if a mother is having a negative blood group and if she is conceiving a positive blood group baby, so what happens is our body will act like producing an antibody. So the baby's blood will, during the placental separation, during the delivery, the baby's blood will get sensitized by the mother's blood group. So what happens, that antigen will enter into the mother's blood. So what happens, we'll consider about the immune system. If something foreign particles is entering into our body, it will act by producing antibody, and there in the same way this antigen when enters into the mother's blood due to the placental separation or any other blood rupture, so what happens, that mother's blood group will think that is a foreign particle, that is a foreign body, we have to act by producing antibody. So there happens a antigen antibody reaction. So for the first baby, it will not cause any defect or any harm to that first baby. So next, if we are not administering any immunoglobulin soon after the first delivery, if she is conceiving the subsequent second delivery, what happens is the antibody which is being produced by the mother's body, the same way the negative blood group mother is conceiving the again positive blood group fetus, that fetus, this antibody will go and do the hemolysis of the RBC of the fetus. So if it is doing the hemolysis of the fetus RBC, what happens, the RBC rupture will be there, and that will cause the agglutination. If agglutination is going to occur in the fetal blood group, it is going to affect the cardiac system, cardiovascular system of the baby. That is going to increase the bilirubin level, and also RBC level will also get decreased. So RBC is going to carry the oxygen to all parts of the body. If there is that rupture of RBC taking place, eventually it is going to reduce the oxygen delivering to the fetus, and therefore it will lead to sometimes maceration or the stillbirth in the babies. So only we have to be very conscious that soon after the first delivery we have to administer the immunoglobulins. So we will see in detail about this condition. So Erythroblastosis fetalis, it is a hemolytic disease of human, also known as Erythroblastosis fetalis. Isoimmunization or blood group incompatibility occurs when fetal RBC, which possesses an antigen, the mother lacks that antigen. So that crosses the placenta and it gets mixed with the maternal circulation. So where they stimulate the antibody production. So when the antibody production takes place, that is going to happen a antigen antibody reaction. That antigen antibody reaction is eventually going to cause the defect and also the loss of the subsequent pregnant fetus. That is known as, in simple term, Erythroblastosis fetalis. So that means the antigen, it will be lacking in the mother's blood group. So the antigen which is being present in the fetal blood, it will cross the placenta and get into the maternal circulation during the placental separation. So during that time what happens, the body will produce, the mother's body will produce the antibody, and it will go and attach with the antigen. Their antigen antibody reaction will take place. That is a simple term known as Erythroblastosis fetalis. otherwise Rh incompatibility. So we'll see in detail by this diagram. So let us consider the mother is a negative blood group mother, that is Rh negative mother, and she is conceiving the first baby. So that baby, that fetus is having Rh positive. So during the placental separation, through the placenta, it crosses and mixed. That antigen which is being present in the fetus is going to get mixed with the mother's maternal circulation. So that antigen will cross into the maternal body through the placenta. So what happens? By seeing this antigen, the baby is delivered. Okay, after the baby delivery only the placenta will get delivered, right? That time only what happens? That blood group will get mixed, fetus blood group will mixed with the maternal circulation. So during that time, that antigen is being recognized by the body of the mother, that will produce the antibody, thinking that it is a foreign particle. So it is very common, no, like we get fever, we get running nose. Why? Because the bacterial goes into our body, to that the reaction will take place. That reaction is only fever or running nose. The same way, the antigen is a foreign particle. Our body will produce to fight that antigen, our body will produce an antibody. So antibody is being produced in the mother's body, right? So next, again in second pregnancy, that same negative mother is conceiving the positive fetus, Rh positive fetus. What happens is that antigen will go and get attached to the, recognizing the same antigen. So go and get attached with that antigen, and it is going to destruct the RBC of the fetus. So this is in simple term. So this occurs due to incompatibility of the blood group of the mother and the fetus. So which arises when the fetus inherits a certain blood group factor from the father, that is being present in the father only, but it is being absent in the mother. So as a result, it will lead up into the anemia and increased bilirubin level. So next is, again in the flow chart we'll see Rh negative patient before pregnancy. That leads to, if she is getting pregnant with a Rh positive fetus, during the placental separation, the maternal sensitization of Rh positive blood, that causes, again in the next pregnancy what happens, again she is being conceiving the Rh positive fetus. It is going to take, what reaction will take place? Antigen antibody reaction will take place, and it is eventually going to affect the fetus. That is, it is going to cause the fetal loss also sometimes occur. So maceration occurs, cardiac failure in the babies occur, anemia occurs, hyperbilirubinemia occurs. Like that, these conditions will all occur in the babies due to this incompatibility of the blood group. So next is causes of erythroblastosis fetalis. So erythroblastosis fetalis can be caused due to incompatibility of either two major blood group types. These includes Rh incompatibility and ABO incompatibility. The Rh incompatibility means the Rh system of blood grouping is based on the presence or absence of the Rh factor on the surface of RBC. Factor is inherited protein antigen that was first discovered in the rhesus monkeys. Hence, it is named as Rh, based on the first two letters of the word rhesus. And not all the people have the Rh factor. So those who have this factor are said to be Rh positive or D antigen positive, and those who do not are said to be Rh negative. So an Rh negative mother can conceive a Rh positive fetus if the father is Rh positive. So during delivery, the fetal RBC may enter the maternal circulation due to the leakage. So as a result, the immune system of the mother generates antibodies against the fetal Rh factor bearing the RBC. So the firstborn is usually does not affect it. So next subsequent pregnancy only the babies get affected. So if a mother again becomes pregnant with an Rh positive fetus, her antibodies can cross the placenta and attack the fetal RBC, thereby causing severe hemolytic anemia. So the fetal bone marrow reacts to the hemolytic anemia by releasing an immature RBCs called erythroblast into the fetal peripheral circulation, causing erythroblastosis fetalis. So when only A antigen is present, the blood group is A. and when only B antigen is present, the blood group is B. So when both A and B antigens are present, the blood group is AB. So if both A or B are absent, it is said to be O. The symptoms of and signs and symptoms of these diseases: the destruction of fetal RBC by maternal antibodies against them. So they can range from mild anemia and jaundice to the fetal death in utero. So in the uterus itself, they may cause the fetal death. The major symptoms of erythroblastosis fetalis are mainly briefly discussed in the forthcoming slides. So next is jaundice. So this occurs due to deposition of bilirubin, that is breakdown product of hemoglobin from the RBC. So in the skin and the whites of the eyes. So this imparts a yellowish color or to these structures. That means if we are seeing the babies, no, the sclera will be in a yellow color. So due to the deposition of the bilirubin. So next is hemolytic anemia. So this occurs due to the destruction of RBCs. Untreated anemia can cause heart failure, enlarged liver or spleen, or generalized swelling and respiratory distress. So here the main part is the destruction of fetal RBC. So when the destruction of fetal RBC takes place, these all some conditions will take place. That is jaundice, hemolytic anemia, and kernicterus or hydrops fetalis. These all conditions may occur. So kernicterus means this occurs due to deposition of bilirubin in the brain and the spinal cord. So hemolytic anemia means the bilirubin deposition in the sclera and the body parts. Here kernicterus means the deposition of brain in the spinal cord. Next is hydrops fetalis. So this is the very severest form of disease in the newborn. It is characterized by extreme edema, abnormal accumulation of serous fluid in unusual places like abdominal cavity, lungs, and everywhere. Next is these leads to the congestive heart failure, as the extra fluid causes increased pressure on the heart, reducing its pumping ability. So moreover, the fluid accumulation in the lung prevents the normal breathing. So next is what causes the hydrops fetalis. It is a very serious form of Rh hemolytic disease. So other causes also is there, that is congenital syphilis and congenital heart disease. So in the hydrops fetalis, what happens is due to the excessive destruction of the fetal RBC, that causes severe fetal anemia, tissue anoxia, and metabolic acidosis. So these three conditions takes place due to the destruction of fetal RBC. What all three conditions? Fetal anemia, tissue anoxia, and metabolic acidosis that affect the fetal heart, brain, and placenta. So the hyperplasia of the placental tissue in an effort to increase the transfer of oxygen, that causes, but what happens is the fetal RBC is diminished due to hemolysis. So this causes fetal anoxemia. So that fetal anoxemia will lead to the damage to liver, leading to hypoproteinemia. So this hypoproteinemia will lead to generalized edema and ascites formation in the baby. So that causes macerated, sometimes stillborn also take place, fetal death due to the cardiac failure. So these all are the pathophysiology of the hydrops fetalis. So due to the severe destruction of RBC due to the antigen antibody reaction, these all symptoms takes place in the baby, and later on what happens, it will lead to a very complicated situation, that is sometimes it will lead to a maceration of the baby's stillborn. That means the baby will get dead in the intrauterine itself. Next is how we can diagnose this condition is, one is blood investigation, that is direct Coombs test. It is done on the mother's blood. If she is found to be Rh negative during the antenatal visit, the father is Rh positive, this test will take place. So again, if the Rh negative mother does not have any antibodies during the initial testing, again she will be tested by 18 to 20 weeks and again by 26 to 27 weeks. So if anti-Rh antibodies are detected at any of these time points, immediately we will start the treatment. So next is direct Coombs test. It is carried out on the fetal blood sample. So indirect means we will test on mother. Direct Coombs test means we will detect this on the fetal blood. So what they will measure is, they will measure the level of maternal antibodies attached to the baby's RBC. So this test is done if the fetus shows features of anemia and jaundice. So during the blood investigations, so we will check the blood fetal count blood from the fetal part, and we will check for the bilirubin level and hemoglobin level. So in another scenario, if the baby develops jaundice after birth, in spite of the fact that there is no RH incompatibility, under these circumstances, the symptoms can be attributed to ABO incompatibility. So however, the symptoms are much milder than that of RH incompatibility. Next, we will do the ultrasound. So next is they will do a non-invasive detection by fetal middle cerebral artery blood flow by means of Doppler ultrasound. If the baby's blood flow is affected, then erythroblastosis fetalis is suspected. Next is amniocentesis. This procedure is done to check the, by what they will check the amniotic fluid that surrounds the developing fetus inside the uterus. They will insert the needle and they will take the amniotic fluid and check the fluid for the sample. So this test is done in the lab to assess the baby's risk of anemia. So moreover, the analysis of amniotic fluid can measure the bilirubin concentration to predict the severity of the disease. So if a mother is having this Rh negative blood group, means we will do these all investigation in order to prevent the further complications to the fetus as well as the mother. So what management we can do is yearly phototherapy and yearly transfusion we can start it. So next is, so before baby is born, the following treatment strategies can be followed out. That is blood transfusion. So in the baby which is being inside the womb itself, we can give the blood transfusion, intrauterine blood transfusion. That word we have to consider. Intrauterine blood transfusion. It is being done with the umbilical cord. Next is we can do the, that is deliberately we can do a preterm delivery, that is between 32 to 35 weeks when they have the maturity of the lungs and heart. So once the baby is born, the baby need to be given further blood transfusion, fluid administration should be given, and we have to treat the respiratory insufficiency. So symptomatic management has to be carried out, and essential newborn care and every therapeutic care has to be given. Next is exchange transfusion. This is a special type of transmission to the baby's blood sample is being done. So next is phototherapy, we can start it. So this is to treat the jaundice. So we have seen in signs and symptoms they have the hemolytic anemia or how to say that, increased bilirubin level. So in order to reduce that bilirubin level from the baby's body, we are going to give the phototherapy with the help of the illuminated light, that is going to reduce the bilirubin level from the baby's body. So how we can prevent it? So during the pregnancy, if a mother is found to be Rh negative and the fetus is Rh positive, then anti-D, that is antibody against D antigen, should be administered to the mother at 28th to 34th week of gestation as a prophylactic measure. So during the pregnancy itself, so before the delivery of the baby, we can do this. So if a baby is delivered after delivery, so if Rh negative mother delivers Rh positive baby, then anti-D should be administered to the mother within 48 hours of delivery. That is if she is conceiving and delivering the first baby. So in order to prevent this hemolytic disease in the subsequent pregnancy, we have to administer this anti-D antibody, that is immunoglobulin. So it is an intravenous immunoglobulin to neutralize the maternal anti-D antibodies. This can be administered with the aim of reducing the RBC breakdown and lowering the levels of circulating bilirubin. So next is proper screening can be done out. So like we can prevent it by administering the immunoglobulin. So if we do the proper screening during the antenatal visit of the mother, we can do all these diagnostic evaluations, and preventive measures can be done in a very good manner. So that only we have to do the careful screening. Careful screening, how we can do is like we can check their mother's blood group. So we can so during the first prenatal visit itself, we can identify whether it is a first delivery or it is second delivery, what is the blood group of the mother, what is the blood group of the father. Like that we have to do it, and we have to check their history of the blood transfusions, and further laboratory investigations has to be carried out if we are suspecting for the baby is going to have the Erythroblastosis fetalis. So again, Rh factor immunoglobulin has to be administered, that is Rogam, we will say it in simple term. It is administered at 28th week of gestation and within 72 hours after delivery. So before delivery also we can administer, during 28 to 35 week of gestation, or after the baby is being born also we can we can administer this Rogam to the mother in order to prevent the antigen antibody reaction in the subsequent pregnancies. So next is, even not only that, if a mother is delivering the baby, we have to administer, even if she is undergoing the miscarriage or medical termination of pregnancy, because during the medical termination of pregnancy also, the greatest risk of having, if she is again conceiving, there is a risk of having this antigen antibody reaction. So that time also we have to administer the drug, that is Rogam. So standard dose is 300 microgram of Rogam by the IM route. So this is done to prevent the antigen antibody reaction in the baby. So in simple term, we have seen about the Erythroblastosis fetalis, otherwise known as RH incompatibility, in detail. If you have any doubt, kindly drop down in the comment box. Kindly like it, share it and subscribe it, and thank you for watching.